like I told you guys at the beginning of the semester, one of my objectives as we go through this semester is to teach you how to think critically. When I ask you questions like, okay, if this happens to your patient, then what are you thinking? What are you looking for? What causes that? What are the changes you're going to see in your patient? That's critical thinking. That's the stuff that you're not reading in the book. Critical thinking is when you take the information you've learned with some other information, you put it together and you make it useful to you. On National Registry, they're not going to ask you things directly from your book. They're going to want to see that you can use that information usefully in your practice. So what I'm doing is trying to train you to think backwards so you can learn what you should be seeing and what you should expect or how you can handle something. Because I can tell you how to handle something right here, but when you're out in the field, it's going to look different to you. Every patient's going to be different. I can tell you these set of things you'll probably see, but you're going to see those and maybe some of these, or maybe one of these and a bunch of these. So you have to learn to take the information and make something out of it. So that's what critical thinking is. So we have to make decisions based on our critical thinking and what we've sorted out about our patient. So this chapter is going to mostly highlight how we have to think differently than other medical professions. So we're going to look at diagnosing and critical thinking, how we reach a diagnosis, I think that's so interesting, and how you can learn to think like an experienced physician. Coming out of this class after one semester, there's not this great expectation that you're going to be great critical thinkers. But one of the processes of learning to think critically is taking a bunch of patients with similar presentations and being able to make a judgment about the next patient you see that looks like that. So we're going to talk about that some. Sometimes this chapter seems a little confusing. It's not very long, but I think you can get it. Okay, diagnosis is what we do when we try to figure out what's wrong with the patient. So that's going to be our label for what's going on with them. We're going to look at their history. What do we call their history? The three-word phrase or four? History of present illness. So that's going to be, tell me what's going on right now, why you called 911. That's going to be history of present illness. So we're going to get history. We're going to do a physical exam. You've told me this stuff. Now I'm going to feel for myself. I'm going to do a physical exam. And then you'll get vital signs. And you should be able to put all that together, also take into account their previous history, and come up with a diagnosis. So it really involves two activities. One is a physical activity of doing a physical exam. So you've got to be good with your hands, good with your eyes, good with your ears. And then also your intellectual activity in that you're getting information from your patient, putting that together into some form, and trying to figure out what's wrong with them. Okay, no matter where you practice, we all have ways of how we do our diagnosis. And everybody does it a little, not everybody, but different groups do things a little bit differently. Everybody does it a little bit differently, and it's based on different things. One is how we practice. In pre-hospital, we have to make a decision about our patient in a very short amount of time. So you can see that that's very different from, say, a family practice physician, that sees a patient once or twice a year. They come in, my arm aches, we take some x-rays, try this medication. So their process of a diagnosis may be dragged over several months. Ours is over like 5 or 10 minutes. So we have to process our information much differently than, say, a physician that sees in a family practice. So we're going to be looking at our level of training. We will process things differently. Like I'll reach a diagnosis differently than you will for several reasons. What reasons would I reach a diagnosis differently than you? Okay, I have a lot of experience. I've been doing it a lot longer. What else?
A lot of training.
Yeah, I have a higher level of training. So mine's going to be a little bit different than yours, but you're going to be there. That's what we're trying to get to. Our resources, what does that refer to? In the ambulance, what are our resources like? Yeah, pretty Spartan. Mostly our diagnosis is going to be built up of what we see, what we hear, our physical exam, just based on our assessments. We don't do blood tests. We can't do x-rays. We can't do CAT scans. So there's a lot of things we can't do. So we have to be really good at what we can do. So as I said, the techniques are going to vary. In the ER, they're looking for what's going to kill you too. Now particularly an ER physician, they sometimes lose their patients with people that come in, oh, my back hurts, the shoulder hurts, I have the sniffles, because they're looking for what's going to kill you. They're going to treat those other things, but if you've ever been to the ER, you know that if you're not dying from something, they're going to keep you out in the waiting rooms. They're going to be seeing the people that they're afraid may die from something. So they're able to do that, and we kind of do that too. If you've got a sniffles, we're going to treat you, but it's not going to be emergently. So a traditional diagnosis, the way they've done it, over most time, they're going to do an assessment. They're going to come up. You have to bring them down. Did y'all get locked out?
No, I forgot the video.
Okay. We're going to come up with a list of differential diagnosis, and this is a very important term that you know, differential diagnosis. I think we've talked about this once before, haven't we? Mm-hmm. Yeah. And if you think differential, think of different diagnoses. So if your patient said they had shortness of breath, an acute onset, I was sitting here, then all of a sudden I can't breathe, does that sound like somebody with, a chronic respiratory illness? That doesn't sound like it's a chronic disease. So if they have an acute onset of respiratory distress and they don't have any respiratory problems, then when we're making up our list, it could be this, it's not this. In the list of it's not this, we're going to put, COPD or pneumonia or some of these disease processes. But we might keep in here things like, a spontaneous pneumothorax, like you had a collapsed lung, or a pulmonary embolism, which would be a blood clot in the lung. Something that would be very acute in that it came on very suddenly. So that's our differential diagnosis. It could be this, it's not this. So we may start out with a long list of it could be this. My stomach hurts. My stomach really hurts. Well, our list is going to be very long and distinguished. Well, we're talking to a male. Their stomach hurts. We know it's not what?
Pregnancy.
Yes, they're not pregnant. They're not premenstrual. Those things we can X off that list. So you'll move things back and forth based on what you hear from your patient and what you can rule out. And as you kind of more clearly define that list or shorten that list, as you continue your assessment, then you're probably going to zero in either with a specific diagnosis or maybe a couple things that it's most likely. So when you're doing your differential diagnosis and you've kind of ruled things in and out, now you're going to start to reevaluate the ones you've left in here and see which one of these most likely would it not be and what it most likely would be till you reach your final working diagnosis. Now for us, it's just a working diagnosis because we don't have blood tests, we don't have x-rays, we don't do CTs. There's so many things we can't do or that we don't have access to that type of testing. But we still, surprisingly, probably 95% of the time, we're spot on because we just see it so much. I read something on Facebook the other day from a friend who's a medic down in Mobile, and he said that he had gone to the ER and spent 4 hours in the ER for the doctor to tell him he had, I can't remember what it was, but he called his buddy who was also a medic and said, hey, I've got this, what do you think it is? He goes, oh, well, it's blank. Sure enough, that's exactly what it was, and he didn't even lay hands on the patient. So you'll find that we're very good at it if you'll trust your instincts. But you got to have a lot of knowledge behind that moving forward. So what we want to do, the goal or objective of our diagnosis is to sort out the things that will kill your patient from the things that won't. We'll always keep on our list the things that are likely to kill our patient. Those are most important until we can rule those out. And if we have a list of 2 or 3 things, I'm going to treat for the most deadly thing first because that's what we're here for. We want to rule out or treat any immediate life threats as we find them. We want to stabilize that patient, at least till they can get to the ER and get some further treatment. We may have to gather more information. It may be we need a list of those medications. We need to talk to a family member to check on the mental status. But as we're doing that differential diagnosis, we're just going to ask a lot of questions. we want to try to rule out the worst case scenario first, if at all possible. So think of the worst thing. If you've got a patient, say, that was in a head-on collision, the airbag deployed, they say their chest hurts. Well, I want to think of the things that are going to kill your patient first and try to prove those wrong. Okay, so if I look on there and I see bruising on the chest, that's going to move serious over here. If they tell me that that was pre-existing, that they had fallen, that bruise was already there, well, I can discount that bruise possibly. If they're having respiratory distress, well, that really stays in the list of very serious complications. So that's what you're going to do. If they say, you know, my tooth hurts, is that going to kill your patient? It's not going to kill my patient. Might kill them over the long term if they don't ever have anything done about it, but it's not going to kill them within 15 minutes or 30 minutes, right? So they're going to go in the not so serious. But if they say they have pain in their jaw and it feels like a toothache, well, a toothache ain't going to kill you, but what else could be a pain in your jaw? Yeah, well, you probably remember some kind of trauma there.
Internal broken here, but squashed.
Say no trauma. Y'all not reading.
Heart.
Huh?
Heart.
I have a heart in my neck?
It can radiate that way.
Exactly. It can radiate up. So a patient that says they have, it hurts here and it feels like a toothache, that's not an unlikely presentation of a heart attack. They may not say they've got central chest pain. They may say the pain is right through here and it's a heart attack. So you're just going to have to ask more questions. If they say I have a toothache, whereabouts does it hurt? You know, if they say it's been hurting for 4 days, it ain't a heart attack. But if they say, well, I was just sitting here and it started and it kind of hits here, then you're going to start asking questions about radiation, right? In a scale of 1 to 10. So that toothache now is going to stay in our this could kill you column. But if it's been hurting them for 4 weeks and the dentist said they had a cavity and they just can't afford to get it fixed, you're going over here and, you know, call somebody else column. Not really. But we want to try to stabilize our patients, get as much information as we can, but we want to rule out the worst case scenario. I want to be able to say, oh, you've had this for 4 weeks and the dentist told you you needed to have a root canal. I've just ruled out a heart attack for that guy, right? So sometimes gathering more information, asking questions, will assist you in ruling out the worst case scenario. So if you get a red flag, and that's an important term, a red flag would be something that sets little bells off in your head. You know, if the patient says, you know, I've got pain right through here, it's very severe, that's going to be a red flag. It's like you go in and a patient tells you he's had night sweats and he's coughing up blood. Those are red flags. Do you know what those are red flags for? Tuberculosis. So as we move through the upcoming chapters, I want you to make note cards with every single disorder or disease that we're going to cover and write down the signs and symptoms so that when you hear something, immediately it's going to tie you to it could be this, 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 or this, and then as you start getting more information, you rule this out, and you're left with this. But if you don't know what accompanies or the signs and symptoms of each one of those, you're not going to recognize it in red flags, and you're going to kill somebody. That's never good. If you find that several patients have the same presentation, that's going to tell you something too. Those are red flags. Okay, let's look at our approach to a diagnosis. We have to be very good at it. We have to be very efficient and very quick. To be good in EMS, you generally have to be fairly self-confident because you're having to make critical decisions. You have to get in there, work, and get out. You have to feel confident in your decisions. If you start second-guessing yourself, you're just never going to get anything done. And that's not something that comes naturally. You walk in this class, now I'm confident, I've got all this. It's something that'll build as you go through class. When you finish and you pass National Rate for the first time, yippee, you feel confident, and then if you decide to move on, that's going to build on your confidence. But we have to be very efficient, and that efficiency is going to be based on our ability to do a differential diagnosis very quickly. We also have to be efficient because we have to be ready constantly for calls. You know, I can't spend an hour and a half with a patient trying to figure out what's going on with them. So we have to be very quick. Now, we also work in a very uncontrolled environment sometimes. You know, whoever's going to be working up in Dayville tomorrow afternoon, that's going to be an uncontrolled environment. We got tornadoes, we got hurricanes, uncontrolled. We can have pouring rain, uncontrolled. You know, it can be snowing out there. So it's not like we work in the ER where we can just adjust the temperature and the lighting to suit us. It could be dark out there and our lights are not, you know, bright enough. It could be foggy. So very uncontrolled environment. We don't have a lot of tools, and the skill set may or may not be limited. You know, you haven't seen everything, so your skill level won't be as great. One thing that's different about EMS than, say, nursing or PA or something else, we have a very narrow focus. What is our focus on? I've said it about 15 times. What?
Keeping them alive.
Yeah. What's going to kill you? I don't care if you've had a rash for 3 weeks. Now, we work in the nursing department here, and I'll get students, sometimes they'll come in and they'll say, you know, I've had this for 3 weeks. Don't ask me, you go ask a nurse. If it's going to kill you, we can talk about it. But if you've had it for 3 weeks, you need to go ask somebody else. So we have a very narrow educational focus, and it's very concentrated, it's very intense. If you've ever worked a cardiac arrest at a doctor's office, you think those people have not even graduated high school. But they don't work cardiac arrest. They don't know those drugs. They probably don't know how to do CPR. They did it back in med school to get ACLS or something. But since then, they haven't done it. So we are very good at what we do. So when we talk in the legal chapter about intervener physicians that show up on scene, they may be very, very good at whatever it is they do, but they're probably not very, very good at what we do.
That's what I was fixing to say, or the flip side of it. They show up on a scene to help you, and all it is a hindrance because they have no clue how to.
Yeah, they can do some things, but they don't usually learn it to the intensity that we do. I have a lot of nurses that, I used to teach a EKG class. It was just 2 hours. And we would get some nurses that would enroll in that because nurses don't learn rhythm strips. They don't learn cardiac rhythms. Now, they learned some treatments and some management and assessment, but they couldn't look at a strip and say, oh, that's, you know, well, some of them they could, but mostly they can't. So we have a limited educational base, but we're very good at that limit. We're like specialists. You know, you're like going to some specialists out there. They think you've got whatever it is they treat, but, you know, your general stuff, you tell them you've had a rash for 4 weeks and they're OBGYN, they're going to see somebody else. Same thing we do. If it's going to kill you, let's talk. Otherwise, go somewhere else. So we basically follow the same steps as an emergency physician is, because his job in the ER is to sort out who's fixing to die or who's got some, you know, disease process that's going to kill them. And they're going to focus on those first because they don't want anybody dying in their ER anymore. We want anybody dying in the back of our ambulance. So they do a very quick, a very limited assessment just like we do. We can do a full assessment on a patient in 5 minutes. Of course, you can't ask a whole lot of questions in 5 minutes, but you get pretty darn good at it. Whereas if you go to a family physician you've never been to, he's going to spend 30 minutes getting your history because they're looking at your overall health. We don't look at your overall health. I don't care how you are in a month. I just care how you are during my slice of time, for the most part. So they, as us, we're looking for what's going to kill our patient, what's serious. We rule it in or rule it out. What do we call that? The D words? Differential diagnosis. How soon we forget. So we're creating a differential. Now for you automotive guys, I know there's something called differential in engines, but I don't know what it is. Does that mean, is it like this? To what?
In your axle.
In my what?
Axle.
I thought you said something vulgar back there. All right. You can reach a diagnosis, but your work is not done. What do you got to do?
Treat it.
Yep. You diagnose it, now we got to treat it. You must continually look for information to assist you with your differential diagnosis. And when you have a patient that's got more than one thing wrong, and a lot of them do, you're not done with your first diff. You may have to continue on. And sometimes the other thing that's wrong with them may have an impact on the initial thing, so they're codependent. Okay, if you've been doing this for a while, which at some point I hope you guys will have, you will start using heuristics. Heuristics is a way of reaching a decision based on experience. If it walks like a duck, quacks like a duck, then it's probably a duck. Yeah, and a lot of times you'll find people that go off on these tangents And this goes for on National Registry. When you're reading a question, if it looks like a duck and sounds like a duck, it probably is a duck. Don't be distracted by other things. Is that 100% right? No, but probably 95% of the time you will be right. That's why I don't want you to get tunnel vision, but I don't want you to be chasing purple elephants down the hallway. So these are they're like shortcuts. Like when I said, if your patient says they have night sweats and they're coughing up crud, you immediately think what? Tuberculosis. Is it a chance that it's not tuberculosis?
Yes.
Yeah. But what are the chances that it is?
Uh-huh.
Pretty darn good. So I don't want you to get tunnel vision and say, oh, that's tuberculosis. You'll continue your assessment, but you're looking at pattern recognition. Excuse me. That's one of those red flags that when it goes up, you're gonna chase that dog first. It allows you to be much more efficient, but you've got to keep your eyes and ears open. Don't marry yourself to that route just to find out you've gone down the wrong route because you missed something you weren't looking for. So there are limitations to the shortcuts, but recognize that they can be very helpful for you. They're very time-saving. Thinking like an experienced physician. Now, a lot of you guys are probably in this course because you just don't want to sit behind a desk and do the same thing every day, you know, like putting stamps on letters or something like that. You like the ambiguity of the job. Now, you can be an ER nurse, a trauma nurse, so that you still see a lot of different things, but you're still always in the same environment. You're always working the same people. There's just a whole lot more commonality there. People that work in EMS really seem to thrive on that variation. I want something different every day. Sure, I may see some patients that have a lot in common, but you never know what that day is going to hold. You know, if you take a patient into the ER, they pick them up just like you bring them in, and they do what they do. But we may have to go pull them out of a gully or pluck them out of a tree or, you know, something strange that's going to make every patient a little bit different. Every home you walk into is different. Every family grouping is different. So there's a lot of change involved there. So to be good in EMS, you have to like that ambiguity. You kind of have to thrive on it. Then you have to understand everybody's limitations, not just yours, or your patients' families, and you know what you can do with that. How do the limitations of technology impact an EMT's diagnostic technique? What do you have to rely on?
Yourself.
Yep, you're pretty well self-reliant. If you've ever been in the ER and they say, well, we got to wait on these tests, we got to get that test, that. We don't have those tests. So we're going with what we've seen and what we know, what red flags come up. There's no one single way that's right when you're reaching differential diagnosis. You're going to draw on everything you've learned, trying to see if you can figure out what's going on with your patient. You have to remain flexible and open-minded because things, just like your patients, are, what's the D word? Dynamic. It's always changing. That's the fun part. It's important that you try to learn from others too, particularly when you're new in the field after you get your license. You know a lot of stuff, but the amount of knowledge you leave here with is about 30% of what you're going to get in the first year of practicing. I'm giving you the ABCs. Once you get out there, you start putting it all together. So you can learn a lot from people that have been practicing for a long time. So always ask questions. If you find somebody that doesn't mind talking to you about stuff, ask them questions. Tell me why you chose to do it this way instead of that way. And tell me why you didn't do this. But let me suggest that you don't do that while you're on scene with the patient, because that really will freak them out. And your partner will get very angry. But afterwards, say, you know, I was just curious. I thought you would have done this, and I'm curious to why you did that. And if you've got somebody that likes to teach, you can learn so much from those people. If you've got somebody that doesn't like to teach, they're going to think you're arrogant. But ask the ER nurses, and you know, ask if you find some that are compliant. Ask your medical control physician. I've done that plenty of times. Like when you roll into the ER, you drop off a patient, and for whatever reason, that patient just confused you. I just couldn't get a read on what was going on with them. Then you talk to them later on, say, remember that patient we brought in? what was going on there? And then they'll explain it to you, and you'll see what you could have looked for during your time with the patient that might have turned the corner for you. It's also important that you're working from a strong foundation. If you don't know the signs and symptoms of the disease, you're not going to recognize it. So it's important that educationally you're very strong. And then you add on experience on top of that, and you'll be great. Got to be familiar with the conditions. You also have to remain up to date with stuff. Things are constantly changing. I was talking to a girl the other night. She goes, yeah, well, they just changed this. She just read about it. I went, hadn't read that yet, but I know I got to get back into it. There are publications out there, plenty of things that you can do to stay up to date. Medicine is constantly changing. That's one thing you can be sure of. They may not change architecture. They don't change math. They don't change chemistry. But the practice of medicine is constantly evolving. There are things that we used to do 20 years ago that, oh my gosh, if you did that today, you'd be killing your patients. Well, we killed them back then too, but we didn't recognize it. So things are constantly changing, so you've got to stay up to date. Now, if you're going to be a good thinker, a good critical thinker, you have to be organized. Remember when I was showing you how to do the trauma assessment with your hands on, doing that? That was a very organized approach. What happens when you've got so many things going on all the time, it's very easy to get distracted. Anybody in here get distracted easily? That should be just about everybody. If you don't raise your hand, you're lying. That's why you're in here. Yeah, you're very distractible. And it's because we like different things. We like change. So we're distracted easily. So we have to make sure that we remain organized. So if you get a pattern to how you practice, then you'll do it the same way every time and you won't make those mistakes. I've told you there have been several times where I've been so grateful that I had those sheets memorized because I've been able to go back and say, what did I miss? And go through there. And when you've got people shouting and rain pouring down and just total chaos everywhere, you've got to remember to be focused and be very organized or you'll screw it up. What are some important things to remember as you learn how to make a diagnosis and improve your critical thinking skills? What have I got? Reaching a diagnosis is a process. You don't just walk in, look at a patient, see they look like a Smurf and go, they're hypoxic, right? We have to know a lot more, don't we? What do we have to know? Yeah, we got to know their ABCs. Mainly we're looking for, how did you get here? You're hypoxic, you're blue. What process got you here? And by going through the ABCs and get our, have you had this before? Is this pre-existing? What happened when this happened before? Give me the history of present illness. We get all that information. Now we can treat them. So we got to figure out how we got to this point. And that's basically what we're asking when we do our assessment. This is how I found you. How did we get here? So you're going to ask all those questions. Don't let a diagnosis attempt delay your patient care. If you have a patient with respiratory distress, you don't want to waste time figuring out how we got here. You're going to have to fix it first, and then we'll worry about how we got here. So if it's a life threat, you got a hole in the side of your chest and you're squirting blood out there, let's see, how did this happen? Was it quick? Was it slow? Was it a gun? No. What do you want to do? Put your hand here to control or manage that situation. Now, how did we get here?
As you're putting them on the stretcher.
Yeah. First, we want to make sure you're alive so you can answer these questions for me.
Yeah.
Okay, we diagnose in the field. There was about 15 years ago or so, they went through this thing saying, EMTs don't diagnose. Really? Yeah, sure we do. And as I said, most of the time we're right. If you've been doing this for a little while, most of the time you're right. And there are times where you go in, you'll tell the physician something, and they don't believe you. And then you go back later, and they go, you're right, this is exactly what it was. Yeah, I know. So there's the traditional approach to doing a diagnosis. That's going to be the slow, very organized approach that you may see in a family physician's office. You see some of that in other parts of healthcare, usually not an emergency of any sort. What did I miss that? So the traditional approach, you take your time, you assess your patient, you drop your differential diagnosis, rule in, rule out. You just kind of keep going with that. For us, we don't have time for that. So we have to move forward based on our experience and what we know. So what's that word that we call that? We use the H word? Heuristics. It's important. And what is heuristics? Shortcuts. We're looking for patterns, aren't we? If we see the same set of signs and symptoms in one patient, we see those same symptoms the next day, we see a pattern there. It's not guaranteed, but there's a really good chance that that's what it is. What are the limitations of heuristics? We might miss something. We might get tunnel vision. We might have two presentations that are very, very similar, but when they start running blood tests, they'll say, well, it wasn't that, it was this. So you just got to keep, no blinders. Keep your eyes and ears open, but don't be distracted. Learn to think more critically by accepting ambiguity. There are some things we just won't know. We have to go with what we do know and make the best assessment and judgment and diagnosis that we can. When considering the cause of a patient's condition, don't let your search for a cause delay your treatment. I know that sounds like a no-brainer, but I've seen it lots of times where the person is so caught up with what's going on here and how we got here and why this is going on that they fail to recognize the patient's not breathing. Let's see. You must be efficient yet accurate. Patients often have more than one thing wrong, so don't stop looking. Keep looking. During your whole assessment process, as you're asking questions during your reassessment, try and expand that a little. See if you can draw something else in there with that. All right, you have a 52-year-old man. He complains of chest pain while sitting at his desk at work. He is alert and oriented. He tells you it might just be stress. How would you arrive at at your diagnosis? What do you want to know to find out if it's just stress or could he be having a heart attack? What kind of questions?
Had it longer than a day or so.
Yeah, how long has this been going on? Well, if he says he's been feeling like this for, a month, if you were having a heart attack, you'd probably be dead by now. All right, what else would you want to know?
Any previous heart problems?
Yeah, previous history. If he's had 2 open heart surgeries and he takes a list of meds, he tells you he's got chest pain. Are you thinking stress?
No.
Oh, no, sir. Get on that stretcher. We're leaving. Is he having a heart attack? You don't know. Well, what are the chances that it's that and not I'm having stress? It's pretty darn good, sure. So anyway, yes, we make executive decisions. We make diagnoses. We make them very quickly. We just have to be good at it. And we don't do the heads or tails method. All right.